Welcome, I'm Julie Rovner. I'm so happy to be here with Kim Keck. Before we get into it, Kim, why don't you give us the 30,000-foot view of what we're about to talk about?
Sure, Julie, it's great to be with you. So during the height of the COVID-19 pandemic, we know millions of people stayed home to flatten the curve, as we called it, right? And in doing so, they put off screenings, checkups, vaccinations, and elective surgeries. And more than 3/4 of adults who delayed care had one or more chronic condition. Also, we know many of those are populations of color, so postponing care could worsen race-based disparities in health. So I think now's the time to ask, what does this mean for the long-term health of Americans and for the future of our healthcare system?
As you mentioned, everybody knows somebody who has delayed or gone without care during the pandemic. I am personally overdue for several medical visits. But what do we really know and not know about how much care has been missed and what the consequences of all that missed care might be?
We know that care was avoided for both prevention and for treating chronic conditions. And more specifically, we know that about 1 in 3 Americans delayed or skipped medical care during the pandemic. And I think I read something like 2/3 of patients said COVID-19 affected their ability to manage their chronic condition. And many of those said that as a result, their condition worsened over the course of the pandemic. Something else we know, the CDC reports that there's increased prevalence of care avoidance from Blacks and Hispanics relative to whites. So this could exacerbate what we already know is true in health disparities. And then on the prevention side, we know from our own data at BlueCross and BlueShield that immunizations for things like whooping cough, measles, polio are down 25%. So just even think about that last statement, right? These are treatments, these are prevention techniques that really could, once they're missed, put people at the greater risk for contracting both preventable and very contagious diseases. So back to your critical question, Julie, about what are the consequences? We don't completely know, as I said, but there are certainly a lot of us studying this issue. One of the anecdotes we've heard, and some evidence, but not significant, is some cancer care specialists really worrying about advanced or severe diagnosis that could have been caught earlier from routine screening. I think we're going to know more soon on those kinds of issues. But here's 2 other things we know. More to do with the delivery system than potentially health of patients. But when we look at the COVID-19 pandemic and we compare it to something like the SARS epidemic almost 20 years ago, one of the things we could see is surge in hospitalizations for chronic care conditions that might have been for care that was not taken care of during the pandemic. We also could see higher demand for provider visits, creating some stress on the system because there could be backlogs for all of us to get back to that routine care that we put off. So a lot to learn, but those would be some observations.
So as you mentioned, the pandemic has shined a bright and not all that attractive light on the way our health system underserves so many populations. Will the pandemic-induced postponement of care worsen those race-based disparities in health, even as policymakers and those in the healthcare system are redoubling efforts to reduce them?
Yeah, I mean, it has, right? I mean, I think one of the things we know from COVID-19, and we saw very early on, is the disparities that really COVID-19 exposed and in many respects exacerbated, right? Some of the statistics that we all have read so much about and are still seeing as we progress through this pandemic is that Black Americans are dying at rates that are something like 1.5 times greater from COVID than white Americans. And Native Americans, that rate is something like 2 times white Americans. Having said that, we also know, Julie, you well know, disparities are not new, right? We see them in a host of other health conditions. We know that Black women, in fact, are 3 times more likely to die from pregnancy-related complications than white women. And it's incredible. It's just unacceptable. We also know Black Americans have the highest death rate and the shortest survival of any ethnic group, racial group for most cancers. And recently, we know the CDC considered or suggested or declared race and racism is a serious threat to public health. So here's the thing. I think we're at a time and a place in our country's history where we are going to see significant action. This is a complex set of issues. It's not one-dimensional. There's not a one-dimensional solution. But Blue Cross and Blue Shield is one example. Our companies have articulated a national health strategy. We're focused on many aspects of this national equity issue, right? So first and foremost, I'll give you a couple of ideas of what's in our national equity strategy. It's advocating for industry standards with respect to collecting data, race, ethnicity, language data. And under the old adage, you cannot manage what you cannot measure. So certainly we need to do better on the basics, but we also need to do things like targeted interventions for chronic conditions that plague communities of color, like maternal health. And in fact, we recently announced that maternal health will be our first focus of our national health equity strategy, with a goal to reduce disparities in maternal health by 50% within 5 years. There's an awful lot of components to it. This is about incenting performance, closing gaps in cares, training providers and members, thinking about basic issues like unconscious bias training and the like, and really some of the underlying root causes of inequities.
I feel like this pandemic has highlighted all of the weaknesses of our healthcare system at the same time. One particular problem that we've had here in the U.S. that many other countries have not had is our continued reliance on fee-for-service care. When there's no service provided, there's no fee, as many providers found out the hard way in 2020. Might the pandemic hasten the transition to other forms of payment?
I certainly hope so. I hope that this crisis provides an opportunity to do exactly that, right? We know that the pandemic exposed serious shortcomings of our health ecosystem. Certainly the public health system wasn't prepared. But as you suggest, the pandemic exposed this antiquated way that we pay for healthcare in the United States, where doctors and hospitals are paid for each and every service they provide, right? And that last year we found out early in the pandemic anyway, really put the healthcare delivery system at financial risk. Exactly as you suggest, I say that all the time, Julie, right? When people weren't able to seek medical services because of shutdowns, there were no services. And as you suggest, when there were no services, there were no fees. And doctors felt this pretty pronouncedly right from the start, right? Many smaller independent practices have suggested that they may close or consolidate with larger practices because of the financial strain when we all, or many of us, skipped routine healthcare in 2020. I think it's something like close to 60% of physicians said COVID-19 would lead to a reduction in the number of independent practices in their communities. And before the pandemic, we had a shortage because there was something like 80 million people, Americans, living in areas of the country that already had a shortage in primary care professionals. So we certainly have to address this weakness, and I believe it's got to be a fix for the next healthcare system we create.
So, is there anything that we've learned this year that helps to provide a roadmap for helping fix the system, particularly the way the pieces of the system work together, or more accurately, don't work together?
Yeah, I think what we were just talking about with respect to the antiquated way we pay for services, it does a couple of things, right? It puts the financial system of the delivery system, if you will, at risk. But it also makes it really difficult to be a patient. And I believe we have to take an opportunity out of this crisis to really advance what we call these innovative models that we've been talking about for many, many years. Models, I believe, that start with primary care, that provide incentives to coordinate care, to get quality care at the right setting, right time, and can deliver better costs over time. I do think, as we talked about a moment ago, the models that existed like that during 2020 really fared much better than our fee-for-service payment models, if you will, particularly when these kinds of coordinated care models were paid on budgets or even what's called capitation. They had better outcomes and at least better stability in how they could manage the populations that they served. And certainly the other aspect we haven't really talked about, but certainly 2020 was a catalyst for, I'll call it telehealth. And I know telehealth, someone smarter than I said, telehealth is not digital health. And I agree. So the pandemic, though, I think gave us the beginnings of what could be digital connected care. So I'm optimistic that these models can work. And I hope that we use this opportunity to make a more accelerated shift away from fee-for-service to budget-based models that are based on primary care and really incent the right kind of coordinated care with the right kind of outcomes.
Kim Keck, thank you very much.
Thank you, Julie.